Welcome to Anatomy and Physiology of the Visual System in Clinical Practice. This is the first lecture in a series of 3. My name is Michael Koloniakis. I'll be presenting this series of lectures. Optometric scope of practice is expanding and it will continue to expand. So it's absolutely critical that optometrists have a core understanding of basic concepts such as anatomical or physiological so that they can apply this knowledge to new techniques or interpretation of techniques as they evolve. So what we will be covering is basic anatomy, physiology, etc. But they'll be very closely integrated with clinical conditions. We strongly recommend the resource of Kansky Clinical Ophthalmology. There are a range of image newsletters available on our website, and also WebVision has some core information about anatomy, electrophysiology, and also visual psychophysics. So let's begin now looking at some general concepts, and the focus will be on the cranial nerves, 7 of which are associated with the visual system. Now, with all my lectures, what you'll note is that near the beginning there's expected level of knowledge and topics to be covered. Effectively, this is the course outline, and either through your core knowledge or maybe you'll need to brush up on some of these issues, that is the expected level of knowledge, and then we'll build upon that in the lecture series. So we'll look at diplopia and how we can apply some basic concepts like, for example, Hering's law or Harrington's law in order to understand the changes in our patients. We'll look at the distribution of nerves secondary, for example, to hepatic disease, and we'll investigate some cases where the understanding of different cranial nerve function allows us to provide a diagnosis. And we'll touch upon some anterior eye conditions. So let's have a look at the 12 cranial nerves. The olfactory nerves associated with smell, the optic nerve with vision, oculomotor drives for the extraocular muscles, trochlear, the superior oblique, trigeminal, one of which is the ophthalmic division, is certainly associated with the eye, innervating the upper lid and also sensory sensation of the cornea. The abducens associated with the innervates the lateral rectus. The facial nerve is also associated in vision in that it innervates the orbicularis muscle, and also in certain conditions, for example, in the blowout fracture of the orbit, there are changes in sensation that occur in the middle face and upper lip, etc., which we'll touch upon later in the lecture. The auditory or the vestibular cochlea is associated with eye movements and with hearing, and obviously our balance. Glossopharyngeal is associated with taste, is involved in active secretions in the pharynx muscle. The vagus parasympathetic component, and also controls voice muscles and the soft palate, in other words, swallowing. The accessory muscle control and ability to shrug and weak head movement are associated with its dysfunction, and the hypoglossal tongue motor innervation and swallowing. It's also important, and what I've outlined here is whether the nerve is purely sensory, such as the olfactory and the optic nerve, purely motor, which is the oculomotor nerve, or whether it's both. In other words, it has sensory and motor components. Now, these are the 6 cranial nerves that are associated with vision that I've touched upon earlier in this talk. Let's first of all look at review some basic concept. The principal visual direction. If we're looking straight ahead, that is our principal visual direction. Now, the issue that we have to consider, and it's important to understand patients, for example, why patients that have a distorted retina, as illustrated here, this is central serous retinopathy, retinopathy report that they have metamorphopsia. In other words, the visual space is somewhat warped. And it's somewhat warped because the principal visual direction of these components, these individual cells here, has been altered because of the serous detachment. So the explanation is relatively simple. So a cell, one particular cell here, has, in its normal location, has a principal visual direction, for example, that could be straight ahead. What has happened in this case, because of serous detachment, the principal visual direction now has been shifted to the side. Now the brain does not know that the retina has shifted. It assumes that visual space has shifted. So consequently, the perception is that, say, for example, a straight line, it's got a bend or is warped somehow. And that is because the principal visual, this component here, is now pointing to something else. Oculocentric direction is very important. For example, in patients that have squint, their oculocentric direction is altered, and clearly what that means is that suppression is a sequelae of that in order to minimize the sort of diplopia. Egocentric direction, in other words, the relative space of ourselves relative to everything else, is altered, secondary, for example, to brain injury. So therefore, reaching and grasping for objects would be impaired. So the point is that all these basic concepts have a clinical application. And what we'll go through is this concept of having a sort of diagnosis or differential diagnosis, this case number 1, which is simply showing to children that have an esotropia. You can see the displacement of the reflex, more so in the image on the right here than on the left. And there's a little rule that you can estimate the turn in the eye, which is clearly more in this child here, where the reflex is close to the limbus compared to the child on the left. And here's the rule here. It's about each millimeter displacement is approximately 7 degrees, which corresponds to about 14-15 prism diopters. Now, I would strongly recommend that you go to this particular website, which is at the University of California, Davis, and look at some of these simulations, and to refresh your memory or to look at something slightly different. There are some demonstrations where they explain some of the concepts, and there's also a quiz that you can test your knowledge. Now you can create virtually anything that you want. For example, what I've done here is created a left cranial nerve 6 palsy, and you can see the eye moving in, and the reflex is now closer to the limbus compared to where it should be, just displaced slightly by about 1 millimeter. So here's our case number 2. This patient is complaining of diplopia and numbness along his face, and it's this region here that there's a change, and you can see a little bit of redness, and this typically occurs secondary to some blunt trauma to the eye, but can also occur in patients that have chronic sinusitis, and secondary to a severe sneezing attack has been reported. They end up with a blowout fracture of the orbit, and you can see this in this patient here, where there's severe enophthalmos. In other words, the right eye goes back into the orbit because of the blowout fracture of the orbit. Now, the reason the patient has numbness along this region here is because the infraorbital nerve, which is part of the maxillary division of the 5th cranial nerve, is affected. It runs along the floor of the orbit. So anytime you have trauma, and in fact, after the surgery, after the repair of the blowout fracture, typically it gets worse. This numbness gets worse, and it will take about 2 to 3 months potentially for it to recover. Now here's an example of a left blowout fracture. The patient had a right, showing the floor of the orbit and the ethmoid bone here, which are the 2 thinnest bones of the orbit, being broken. The bone is broken here, and you can see compared to the other eye, which everything is intact. Now the There is no surgical repair for the ethmoid bone, but certainly this is typically repaired, particularly when there's restriction in eye movements. It's only a small blade fracture, usually they don't operate on it. Let's now go on to a third diagnosis, and we see that there's some lesions here on the tip of the nose. And this, of course, is known as Hutchinson sign, because the ophthalmic division of the fifth cranial nerve innervates the tip of the nose. And if we look at the different parts of the fifth cranial nerve, the ophthalmic, maxillary, and mandibular division, the nasal nerve here is part of the ophthalmic division. So what that means is that if a patient has herpes zoster virus that has progressed to this part of the nerve, one thing is certain is that the ophthalmic division, this part of the ophthalmic, in other words, the one that innervates the cornea, will also be affected. Now, it's often forgotten, everyone is looking for Hutchinson sign, but it's not uncommon for there to be some follicles or some formation in early stages in the eyelid. It is possible. It can be in different location. It could be Hutchinson signs, or it could be some follicles here, which means that there will be an ophthalmic component to the herpes zoster. And if you've had some patients that have had herpes zoster ophthalmicus, they will tell you it's one of the most severe forms of pain that they will ever experience, that they have ever experienced. Here we have a case where sort of end-stage herpes zoster, and you can see the distribution of the ophthalmic division of cranial nerve is virtually identical. Here it is in the right side of the face, identical in this patient, and end stage. Now, the very critical thing to remember is that if you suspect that your patient, for example, patient comes in with signs where they can potentially have herpes zoster, it's very important that they get put on systemic acyclovir, typically within 48 hours. The effect of systemic acyclovir is significantly reduced, which means that the course of the disease is longer, and post-herpetic neuralgia is also increased if acyclovir is not provided to the patient early on in the disease process. Let's now move on to our fourth patient. And this particular patient had a 6-day history of neurological dysfunction. They had difficulty eating. In fact, at the day it happened, and a couple of days afterwards, when he was trying to eat, there was the food was almost coming out on the right side of his mouth. There was slurred speech, and there was gait difficulties, and there were headaches. The doctor checked him out and everything, and I said, well, I'm not sure exactly what the problem is. But let's have a look at this patient carefully. What we can see, that the right side of the face is different. The muscle tone is slightly different on this side compared to the other. When we look at the eyes, we can see the upper lid is slightly abnormal, but the biggest difference is this droopiness of the lower lid. And you remember from your basic anatomy that we'll review shortly, is that the orbicularis muscle, which is innervated by the seventh cranial nerve, is the muscle that controls a lot of the facial component, facial muscles here, including the orbicularis muscle. So the immediate suspicion is that there's some abnormality with the seventh cranial nerve. So let's have a look at what determines the size of the palpebral fissure. You need to remember two numbers, 1 and 3. 3 refers to the 30 millimeters, which is the horizontal diameter, and 1 refers to about 10 millimeters, which is the vertical diameter. If you remember that, then you have to say, okay, what controls the size of the palpebral fissure? Moore's muscle, which is a tarsal muscle, which is under autonomic nervous system control. In other words, we can't voluntarily control that. Whereas the levator pulpobase superioris, which is innervated through the superior division of the third cranial nerve is involved in lid elevation. So if that is dysfunction, there will be lid drooping. If Muller cells is dysfunctional, there will also be lid drooping. The orbicularis muscles, which is also under somatic control, controls blinking and eye squeezing when we want to forcefully close our eyes. So here's a schematic of the Muller muscle. In fact, there are two muscles, but clinically I'm not aware of any clinical condition affecting the inferior part, but certainly if there are anomalies in the autonomic nerve supply, which we'll touch on later on in the lecture, there is drooping of the eyelid because of the poor innervation of Muller's muscle. The LPS, or levator pulmonaris superior, is innervated by the superior division of the third cranial nerve, and when we look up, it is the LPS that is used to lift the upper eyelid. So let's have a look at the orbicularis muscles. There are two major components relevant to the palpebral fissure. The orbital part that's the one that's involved in forced eyelid closure, and the palpebral part, which is the more inner part, is our normal blinking. When we normally blink, it's the palpebral part that is closing our eye. So let's now have a look at this particular patient and how we can use this information to provide a tentative diagnosis and help the GP in particular to order some suitable tests. So here's a normal location. Then in order to test the seventh cranial nerve, you can ask the patient to puff their cheeks, show their teeth, they can frown, which is smiling here, which doesn't appear to show any major seventh cranial nerve dysfunction. So what that tells us, if it is a seventh cranial nerve, it's relatively subtle. You can then ask them to please close your left eye, which he was able to. And I've known this gentleman for many, many years, and I know that he can independently close the right and the left eye. So when I asked, please close your right eye, this is what I got. In other words, he has lost voluntary control of closing the right eye. If that's the case, then say, well, maybe if it is seventh, how can I test whether the function besides this is anything else that I can do? That's when the knowledge of the integration of different cranial nerves comes into play. If we stimulate the fifth cranial nerve, get a cotton bud and stimulate the cornea, the information will go to the seventh cranial nerve and there's a reflex blinking. And the left seventh cranial nerve innervates both orbicularis muscles to get the blink reflex. And that's exactly what this patient did. When I touched his cornea, we got a bilateral blink response. I then touched his right cornea and there was no blink. So one of the possibilities is it could be a fifth nerve dysfunction. So you can ask the question, when I asked him, if I stimulated this eye, do you feel it? Yep. When I stimulated this eye, do you feel it? Yes. So in both cases, he could feel the stimulation. So in other words, the fifth cranial nerve is operational, but clearly the information coming back from the seventh cranial nerve to lead to a blink reflex is dysfunctional, as is the voluntary control of closing the right eye. So in this particular case, the MRI scans and the CAT scans were absolutely normal, but that doesn't mean there isn't a small lesion somewhere in the seventh cranial nerve. All it means is that the investigations simply didn't pick up the very subtle anomaly. But this patient has had an acute episode of very likely a small stroke that hasn't been picked up either by the CAT scan or the MRI, which has led to the facial change here, seventh cranial nerve, and innervation anomalies as far as the orbicularis muscle is concerned. So what I've tried to demonstrate in this part of the lecture is that if you have an understanding of the different components, you can then understand the ocular disease, for example, herpes zoster ophthalmicus, and investigate changes that occur secondary, and the example I gave of the seventh cranial nerve. So there are very simple tests that optometrists can do to test the different visual function. We certainly do a lot of tests to test the second cranial nerve, the third, the fourth, and the sixth cranial nerve. But there are other tests, very simple tests that we can do to try and isolate other parts, other cranial nerves associated with ocular anomalies. Let's now look at pupil anomalies, and in this, what I plan to do is just touch on a couple of key concepts that hopefully will allow you to investigate your patients fully in order to arrive at a suitable diagnosis. Just a summary, the pupillary pathways involve direct, consensual, near. There can be an absolute loss or the Marcus Gunn type pupil. The RAPD is probably a better term, and I'll define that in the next slide. And we'll go through some basic pharmacology. Just like the extraocular eye movements, the University of California, Davis has a pupil applet. And I'll show you some examples that, again, I think is really excellent to review your basic knowledge and also test yourself out, because there are some quizzes there. So the pupillary defects that are probably most relevant to optometrists is Horner's, relatively rare, but it's absolutely critical to be able to diagnose this. The Holmes 80 pupil, which is relatively common, you'll see a lot of these in clinical practice. You need to understand the pharmacology. And very importantly, whenever you're dealing with ocular disease is really symmetrical. There is often a very subtle RAPD that you need to be able to pick up. So what is an RAPD? So effectively what we're doing is looking at the relative pupillary response by doing the swinging flashlight test. And if there is an asymmetry in the pathology, whether it be retina and optic nerve, you will see a small relative afferent pupillary defect. If you're looking for an absolute defect, it's much harder to identify an absolute, but it's much easier to look at for relative changes. Any lesion before the chiasm will produce an RAPD. And in fact, optic tract lesions, because there are more crossed pupillary fibers than uncrossed, an optic tract lesion will also lead to a small RAPD. And we'll touch upon this as we go along in this lecture series. So here is the UC Davis website. And again, you can identify whatever you want, Horner syndrome, mild or marked RAPD, and you can turn the lights on and off and take this flashlight and stimulate one eye or the other. So what I've done here is created a partial third nerve efferent defect. Pupil lid drooping, LPS is abnormal. The innervation to the constrictor is abnormal. Consequently, we have a dilated pupil. And you can move the flashlight back and forth and look at the pupillary responses, look at some demonstrations, and then undertake a quiz. Again, I think I emphasize that's very, very useful science, very helpful in solidifying your understanding. So in general terms, what is the autonomic nervous system responsible for? The flight reflex, the sympathetic nervous system, and these are the changes that occur after stimulation. And then you've got the couch potato, which is the parasympathetic system. So you have two different components that are associated with different aspects of bodily functions that are subsequently important for you to understand, because it is the sympathetic and parasympathetic nervous system that innervate the pupil. And there's some key pupillary functions, and also the lid drooping that occurs secondary to the sympathetic de-innervation that occurs in Horner syndrome. So let's have a look at schematically the different components. We have the autonomic nervous system that in the first synapse here, before we go to the effector, that uses the choline. Parasympathetic nervous system also uses the neurotransmitter acetylcholine. The receptors at both of these sites, the synapse before the effector is in both cases are nicotinic receptors. So the same receptors, same neurotransmitters. On the effector cells here, this one uses norepinephrine or noradrenaline, and the other uses acetylcholine. Now, acetylcholine on the sphincter, unlike the nicotinic receptor, uses the muscarinic receptor. In fact, it's the M3 muscarinic receptor. So if you stimulate this receptor, as you would with pilocarpine, the pupil constricts, or if you block this receptor, for example, using tropicamide, then the sphincter doesn't work, therefore the pupil dilates. So you can affect it one way or the other. Now, norepinephrine or noradrenaline, this is on the dilator, so if you stimulate the dilator muscle, the pupil dilates. And an example of this is aproclonidine. For example, this is an anti-ocular hypertensive drug, but it's not a selective alpha-2 receptor agonist, which is what brimonidine is primarily, an alpha-2. So if you put aproclonidine in the eye, what you can get is slight pupil dilation, because it's activating this receptor. And the other thing you can also get is lid retraction. So aproclonidine being a non-specific adrenergic receptor. So the receptors in this, the effector here is alpha-1 receptors. The receptor here is M3, and M refers to muscarinic acetylcholine receptor, and the adrenergic receptor here is the alpha-1 one. So yes, so it's alpha-1 and M3. These are the two receptor types. Let's now have a look at the sort of parasympathetic and sympathetic nervous system, how the information gets to the iris sphincter. The ciliary ganglion is in the eye, and what that means, this is where the acetylcholine and nicotinic receptors are located. What that means, if you have an injury here, or if, for example, in Adie's pupil, where there's thought to be some type of viral infection here, you will end up having a slightly dilated pupil. But you can also get it secondary to injury. Now, when I was on sabbatical in the ophthalmology department of Salt Lake City, there was a patient, an oculoplastic surgeon, showed us a patient just before he took him into surgery to repair this. And what had happened, this gentleman had an argument with his wife, and they were obviously located in the kitchen, and he ended up with a very large knife in his eye. The amazing thing was that the eye was okay, everything was okay, except that he had a Holmes-Adie-like pupil. Technically, it's an Adie's-like, because in order to get the Holmes-Adie pupil, you have to have an absent knee jerk, and these patients typically, if they have Holmes-Adie pupil, will also typically have postural hypotension. So here's an example, having an Adie's-like, or Holmes-Adie-like pupil secondary to injury. The sympathetic pathway begins somewhere in the hypothalamus, and there's three components. There are first-order neurons that synapse in the spinal cord, and the sympathetic chain, which is located around near just below where the carotid bifurcates, just above the lungs. So you can see in this region here, if a patient has lung cancer or breast cancer and there's been metastasis, the sympathetic chain will be affected. And because they're affected in the second order neurons here, what the patient will have is potentially a Horner syndrome, the lid drooping because Mueller's muscle is de-innervated, and there's a pupil constriction. But also at the same time, they will have absence of sweating to the face and sort of shoulder neck area, and that's be slightly red, because there are also pseudomotor and vasoconstrictor fibers that are along the sympathetic chain. If a patient comes in with Horner syndrome and there's absence of sweating on half the body, what that means is that the lesion is likely somewhere here, which is, it's not a very positive outcome in these patients. And also here, because there has to be metastasis, it is a fairly advanced condition in order to get Horner syndrome secondary to lung or typically breast cancer. If the lesion is only if you have a purely Horner syndrome and the pseudomotor and vasoconstrictor anomalies on part of the face, what that means is that the lesion is likely to be located here, further up. So let's now have a look at case number 5. A patient, a young lady that comes into your practice. Visual acuity is normal. There's no signs of symptom brainstem lesion. Extraocular muscle movement, the eye movements are absolutely normal. There's no liptosis either. So the dilation pupil, the number one you should think of is pharmacological installation. And number 2 is potentially it could be third nerve involvement. Now if you remember your basic anatomy, the third cranial nerve, the pupil fibers are superficially located. And what that means, that is if you have an ischemic injury to the third cranial nerve, you will get potentially pupil may not be involved because it could be bathed by the cerebrospinal fluid. You will get extraocular muscle anomalies. Now in this particular case, because there is no, the lid is fine, you haven't got the droopy lid, the extraocular muscles anomalies are normal. There are no extraocular muscle anomalies. It suggests that it may not be some type of ischemic or lesion. But also it is it is possible that in the early stages or even a compressive lesion that you can get pupil involvement but no extraocular muscle involvement. So you need to exclude this, whether it's some type of compressive lesion, whether it's some pharmacological type of involvement. So when you look at pupil reactions, you can stimulate this eye, pupil constriction, so the afferent loop is normal. If you stimulate this eye, you get pupil constriction and no reaction here. Now, if you had a compressive lesion leading to this dilatation, if you put a constricting drug here, the pupil should constrict. But if you had a pharmacological, if a patient accidentally or purposely put a drug in the eye to dilate, if you put pilocarpine in, you will get no constriction. And in fact, after the application of pilocarpine, there's actually no change in pupil, and in this case, see the pupil constricts. So what that tells you is this lady either often happens, the child has some drops and the patient has a sore eye and they put it in and they walk in like that, or they could be a diver, so it's not uncommon for scopolamine to be somehow inadvertently being put in the eye. So a very simple way to discriminate between a lesion affecting the third cranial nerve versus a pharmacological installation. And keep in mind, obviously, to investigate third cranial nerve function in whether the LPS is functioning properly and the extraocular muscles. Let's now go on to case number 6. This is a middle-aged gentleman that walks in complaining that his left pupil is becoming a little bit bigger, and he also has some photophobia in the left eye. He's noticed it over the last couple of weeks. Now this is a typical presentation, and one of the things you should ask or should check whether they have an absent knee jerk, and also ask them when they stand up, do they sort of feel giddy? In other words, they have postural hypertension. So there is a sluggish, when you do investigate these patients, this sort of sluggish constriction, and over time this pupil may get a bit smaller. But this is sort of a classical 80s pupil, and if there is absent knee jerk and postural hypertension, you can call this a Holmes 80 pupil. So the reason it occurs is because the neurotransmitter release to the sphincter has reduced. So in other words, the ciliary ganglion is abnormal, and typically these patients would report that they've been unwell, they had some type of viral injury. Now, if there is a lack of release of neurotransmitter, what typically happens at the post-receptoral site, there is an expression of more neurotransmitter receptors in order to compensate for the lack of neurotransmitter. And what that means, we use that clinically because there's no change here. There should be more receptors here. So when you use very low concentrations of pilocarpine at a concentration where the right eye would not be affected, this pupil constricts. And this confirms that the patient has Adie's pupil. I would strongly recommend that there's some beautiful Kitcombe has provided a series of basic pharmacological reviews that you can download. They're freely available on the net, and they cover a whole range from basic pharmacology to clinical pharmacology. So the key points to appreciate as far as the pupil reactions are concerned: understand the basic concepts of what controls the size of the pupil. If you understand that and its innervation, then you can very easily determine whether you have an afferent defect, an efferent defect, whether you're dealing with a condition where the pupil anomaly is present because of some type of eye disease, whether it be retinal optic nerve or even optic tract. So these all, if you understand the basic concepts, you can very easily apply it to clinical practice. So let's have a look now at some examples of anterior eye imaging, anterior eye conditions. And like any condition in the body, it can be due, the anomaly could be due to some type of infection, could be due to a dystrophy, a degeneration, secondary to some type of inflammatory disease, could be age-related, or it could have some type of metabolic, ischemic, or toxic, something falls in the eye, if it's anterior eye. You can have mechanical damage, or you have some congenital anomaly that the patient is born with. Now, often with these congenital anomalies, they could be innocuous, or they could cause, or they could lead to some type of degeneration. So this is patient number 7 that was referred to us because the patient had pterygia surgery. But you can see, if you look very carefully, this part of the cornea is in fact hazy, and he wanted to determine why is this occurring, and also to get some imaging done of the pterygium. So if you do an OCT image, anterior OCT through this, what you can see, the pterygium, so going in between the epithelial cells here and the stroma, so it's almost just pushing into the eye. And if in this particular schematic here, which is a bit lower, you can see that the pterygium is on top of the surface, which clinically really is a better outcome. But you can see in this image here why the patient, all this region here, is edematous, and that's because there's been endothelial detachment in this patient here, leading to swelling of the cornea here compared to the normal where the endothelium is attached. So then the surgeon has sufficient information to deal with this edema as well as the pterygium. Now there's a couple of very interesting abstracts a few years ago at ARVO. So there's a Japanese group that reported that if this pterygium was penetrating into the cornea as the first example, which was up here, then corneal scarring occurred secondary to surgery. Less so in cases like this. So this actually gives quite useful information to the surgeon whether there will or will not be corneal scarring. And another very important thing is that even though we may measure visual acuity, etc., they also looked at high order aberration using imaging modalities and showed that it is possible, even though the cornea may look nice, there are distortions that we can't detect through the high resolution. When we use High contrast letter is simply below acuity, but the patient may still complain of visual disturbance, and that is because the peripheral cornea here is causing higher order aberration that distorts the vision. But without using imaging modalities, we simply cannot detect that. So let's now have a look at patient number 8. The patient was referred for a glaucoma assessment because of these changes here that the optometrist noticed. And these changes is a pseudoexfoliation material on the anterior lens and on the edge of the pupil here. And you note that the pressures, when we measure them, are pretty normal. There's no major change there. So this patient very likely has pseudoexfoliation syndrome. Now, if there are optic nerve head changes, visual field changes, the patient would then have pseudoexfoliation glaucoma. So let's have a look at the optic nerve. The right optic nerve looks okay, it's pink all the way around. The left optic nerve is different. There appears to be cupping, and there's quite a distinct difference between right and left. If you look at the visual fields, the left eye has a classical arcuate visual field deficit. The right eye, potentially the beginning of one, but certainly there is a repeatable visual field change in the left eye that corresponds to the anatomical change. Now in this patient here, we can do an OCT. You can see all the exfoliative material that is located on the lens and on the edge here of the pupil, and say, okay, this is a classical pseudoexfoliation syndrome, likely in this case glaucoma because of the optic nerve and visual field changes. But this material is in a way the least significant anatomical change, and you'll see why. So we always worry about pseudoexfoliation, glaucoma, etc. We don't think much about the front of the eye. So let's have a look at the endothelial cells in this particular patient. You can see all these regions here almost look like cornea guttata. And what we have is, typically in some patients, you can get corneal edema that secondary to pseudoexfoliation syndromes. What happens, there's damage to the endocorneal endothelial cells that become pleomorphic, the shape changes, there's fewer of them, and there's diffuse and irregular thickening of disseminated membrane. Now in this particular patient here, the number of endothelial cells is well within the safe range, but that's something to consider. If you see this, there is the sequelae is that endothelial dysfunction is possible, and other anomalies include the trabecular meshwork anomalies, the fragile lens fibers. So think about when to refer this patient for cataract surgery, because what you don't want is when the cataract surgeon touches the lens, it falls into the vitreous because of the fragile lens fibers. So you manage this patient quite differently to the classical patient that has early cataracts. There has been reports of varus vascularization, vasculopathy, and breakdown of the blood aqueous barrier and anterior segment hypoxia in this condition. So there is a number of additional anomalies that are present in patients that have pseudo-exfoliation material, in addition to the fragile lens fibers and glaucoma that can develop. And in particular, in this particular patient, it's important to keep on looking. This is simply, this dark area here is simply an artifact of photography, but this certainly isn't. This is potentially a nevus or could be a melanoma, and when, in fact when we undertook an OCT, it's slightly elevated. There are some changes that occur in the retinal pigment epithelial photoreceptor layer that could indicate either a nevus or a choroidal melanoma. And because of the size, this needs to be looked at very carefully, and potentially referral to an ophthalmologist who specializes in oncology. And the other thing to consider is that it is very close to the fovea. So ophthalmological consultation is the mode, what we decided to do in this particular patient. So as far as the anterior eye OCT is concerned, there is very useful information that can be provided. But assessing the angle is one of the things that we'll talk about later on in some subsequent lectures. You cannot replace anterior eye gonioscopy with anterior eye OCT. It is some additional useful information that is helpful for you to manage the patient. In addition to that, the anterior eye OCT can be used for a variety of iris lesions and assessment of the anterior eye. And remember that you need to look at the whole eye, whether you look in the posterior eye, and don't get overwhelmed by the changes that exist in the anterior eye, but even things, keep in the back of your mind, what other conditions can patients that have, for example, pseudoexfoliation, think about the endothelial cell change. The patient can potentially have endothelial dysfunction, subsequently edema, and as well as the very fragile lens fibers. That means that these patients will typically have cataract operation a lot sooner than other patients. So in the next lecture, we'll really focus on the posterior eye, on both the optic nerve and retina. And I'll give you some examples of basic anatomy and how we use that in our clinical diagnosis. I thank you very much for your attention, and it's the end of lecture number 1.